Thanks, everyone. To finish off today in a very nice way, on my favourite day of the year, we have a small sample of the research leadership in the Caring Futures Institute. And I must say, a fine foursome we have on stage this morning. We've asked the leadership to talk about how their research, or how the research of their team is redefining care in the Caring Futures Institute. So we have Shekhawat, Julie Ratcliffe, Sue Gordon and Annette Briley to talk to us this morning, but I think we'll start with Raj. Oh, actually it's afternoon, so we'll start with Raj. Now, Raj, you are Professor of Audiology in the college, an honorary professor of the Ear Institute, Public Relations Manager for the Tinnitus Research Institute in Germany, international academic mentor for SCIT, and chair of the Scientific Advisory Board for the Unity organisation, which is funded up to €6 million. And you also have an outstanding track record of 60 peer-reviewed publications at the moment. So excellent work. Tell us how your team, what research your team is up to at the moment.
Thank you so much, Robyn, and good afternoon, everyone. Thank you so much for staying back here. And all the viewers out there, thank you so much for joining us. And I want all of us to do a little activity now. So I want everybody, either here or watching this live, just relax wherever you're sitting, and I will invite you to close your eyes for a few seconds. Everybody, close your eyes, and then think about the most exciting and happiest day of your life till date. Let's just take a few seconds to reflect on that. It could be your wedding, kids graduating, great news about the funding, great time with family members. And now, there's a slight catch to that. Now, you can't hear a thing about that day or that moment. And I want all of you to answer that to yourself. Will that still be your happiest day? Hearing is extremely, extremely important for all of us. Hearing connects us to our environment right from the time we get up from the bed to we commute to work, we spend a lot of time meeting our colleagues, entertainment, social life, all that. Hearing is extremely important. So part of my research is focused on the hearing health on one side. Now, other extreme example of that is not being able to stop hearing. And there's this condition called tinnitus, which is defined as a constant annoying, ringing, buzzing, hissing sound in the absence of its external sound source. Now, for a second, imagine we are sitting here trying to focus on what the speaker is speaking, and we have this constant annoying sound in our head all the time. We are trying to sleep, and we hear that all the time. We are trying to pay attention to something else, but we are hearing that all the time. So my research is focused on tinnitus, which is extremely, extremely common. Like 1 in 8 person in UK have tinnitus, and which cost almost £750 million to NHS every year in GP consults. And similarly, there's a lot of research happening around the world about this condition. My aim is to do more and more novel research to figure out a way to manage this condition. And the techniques which my lab has been using is called non-invasive brain stimulation. And we are trying to use various other forms of sound therapies and hearing aids to see how we can come a step closer towards better management of tinnitus. Because 99.9% of the times, tinnitus occurs along with hearing loss. So I'm really fortunate that right now, as we speak, I have an Action on Hearing Loss funded 3-year project. Right now, we are recruiting a postdoc as we speak. And early next year, 2021, we'll be needing lots of clients with tinnitus and hearing loss. So if you or someone you love have got tinnitus or hearing loss, please do get in touch with me. And hopefully at Health to Go, we'll be running a lot of exciting studies towards management of tinnitus.
Thanks, Raj. That's great. So Next, I'm going to ask Professor Julie Ratcliffe how she and her team are redefining care. Just for those of you who are not familiar with Julie's CV, Julie is a Matthew Flinders Fellow, Professor of Health Economics, an Honorary Professor of the Institute of Health and Wellbeing in the University of Glasgow, and an Honorary Professor of the School of Health and Related Research in the University of Sheffield. Julie has an H index of 39, or Google Scholar index of 52, 238 publications, and has to date received grants and research funding of $30 million. So Julie, tell us about how your team is redefining care in the CFI.
Yeah, thanks Robyn, and thanks for the lovely introduction. So you may be aware of that there's a famous quote that goes something like, economics is the dismal science. And in our team, Health and Social Care Economics here at Care and Futures Institute, we like to think of health economics as the cheery face of the dismal science. You can see hopefully on the slide there some members of my team. So I have a wonderful team, Jenny Cleland, Dr. Claire Hutchinson, Dr. Rachel Milty, who you've already heard of from this morning, Dr. Gyoti Kadka, and Dr. Christine Camber, who's missing from that photograph. So a great team, and we're really focused on driving inclusivity into the methodology and application of health and social care economics. And we've got a large program of work at the moment which is focused on aged care. And historically, aged care is an area which has been basically neglected by health economists. So the vast majority of health economists here in Australia and also internationally are heavily consumed by health system issues, and the aged care sector and aged care research in health economics has really been neglected, and it's an area that we're very passionate about in our team. So we've recently completed a programme of work for the Royal Commission into Aged Care Quality and Safety. We were fortunate enough to walk with the Royal Commission on a large-scale survey of the preferences of the general public here in Australia for what quality of care in aged care should look like, and also to investigate the preferences of the general public for co-contributions towards aged care at the point of access, and also those thorny questions around funding in terms of income tax contributions, and would the public be willing to support increased income tax contributions to fund higher quality aged care. And we found that the majority of our participants would be willing to support increased funding and to provide extra income tax contributions to support funding of higher quality aged care here in Australia. We're also involved in a linkage project which is funded by the Australian Research Council, which I'm leading at the moment, and that's to develop new preference-based quality of life measures for older people in aged care, and we're doing that work essentially with older Australians, so we're partnering with older Australians from inception in terms of what quality of life means to older Australians accessing aged care services, and then we're developing from what the older Australians tell us, we're developing our new quality of life measures. Essentially, those measures will then be fit for purpose in economic evaluation, but also in quality assessment in aged care.
Thank you, Julie. Very impressive. So next, to give us a sample of how we're redefining care in our research, particularly that work led by our research leaders, I'd like to introduce Sue Gordon. Sue is Strategic Professor and Chair of Restorative Care in Ageing. It's a partnership position funded by the ACH Group and Flinders University. She's Chief Investigator on ARC Digital Enhanced Living Hub, and that's flagship research and education director in community and aged care in digital health, in the Digital Health CRC, which is a very large, successful CRC. And she is also leading the development phase of the Aged Care Centre for Growth and Translation Research. And also just a little note, congratulations on the $500,000 tender application support that you received from the Commonwealth. Good work, go forward, do great things.
Thank you. Thanks very much for the opportunity to talk about my research today. And that was me sitting on a rock in the Himalayas, and I hope one day to return. I hope you will get the opportunity to go. It's up in the Valley of the Flowers. So just a little distraction because we're getting close to lunch. So my research. So I think I have a very privileged position to be co-funded by an aged care provider. I have 3 offices, one here at the university, one in a shared space in a residential aged care facility and the university, and one at the headquarters of ACH Group here in Adelaide. And what that means is that I'm co-designing with industry constantly. I sit with the innovation and design team at ACH Group headquarters. And the beauty of this is that I think it jumps some of that gap we have in translation to research. So what we set about doing was understanding what I call the black hole of ageing. We know an awful lot about how we develop from when we're born to when we get to maturity, supposedly at 25. And we know an awful lot about what happens from 60 and 65 onwards, but we know very little about what happens in between. And of course, we don't suddenly wake up at 65 and go, gosh, I'm frail. That's not how it happens. And so we set about understanding what happens to people in that 40 to 75, we stretched it out that far, to see what actually happens. Where do the wheels fall off? And where are the deficits that creep in that we don't actually notice? And I think when we think about those years of particularly 40 to 60, children at home, building careers, lots of competing interests and very little time to look after ourselves. So we set about examining 656 community dwelling participants, and we found that the average number of deficits across all of them was 6, and there was nobody who didn't have a deficit. And so in terms of deficits, everything from hearing, vision, balance, strength, it was a very comprehensive, lung function, very, very comprehensive. But what the actual table that I've shown you there is basically the things that go wrong. So what causes somebody to be not frail and become pre-frail in that 40 to 75-year-old age group? And so I'd suggest most of us are probably in that age group in the room, so perhaps take a look. And then what actually happens from going from pre-frail to frail? What are the things that we need to be addressing? I think the beauty of it is that most of those things are amenable to change. There are things that you can actually do to maintain your not frail status. So in terms of how we're redefining care, I guess the beauty of being, as I said, in a co-funded position is that these pre-frailty assessments have already been included in the usual practice at the gym facilities that ACH Group have, and that happened before this was actually published. We've also, through the ARC, Digital Enhanced Living Hub, which ACH Group are a member of, we've developed a digital app. And this app is actually based on evidence, and it has the screening questions. It has the assessments that you need to do if somebody identifies that they're having some issues. And it can be used by advisors in the aged care setting, and in fact, they're trialling it right now. But it's also been developed to be able to be used by consumers to really assess where they sit in respect of their slippery slide into frailty. Thank you.
Thanks, Sue. Fantastic. So next we'll hear about redefining midwifery care from Annette Briley, but also a special note, Annette is our first, I believe, South Australian clinical chair in midwifery, which after 150 years of nursing, that's a pretty fabulous achievement, I believe. So we're really proud of you, Annette, and really proud that we're making this happen in South Australia. So welcome.
Thank you.
So Annette has international standing for her midwifery research. She's an age index of 29, over 186 publications, and up to date. I don't know what the currency translation is at the moment. It's over 5 million, which is probably 20 million Australian dollars in UK dollars of research and 3 million Australian dollars in research. So Annette, how are the midwives redefining care in your research team?
So I've just been around a long time to have got there, that's what it boils down to. And I am very lucky that I have already seen some of the research that I did in the early part of my career actually change pathways. And it's been quite nice actually. I'm so lucky to have this joint appointment, which as you say is quite novel and new in midwifery in South Australia, but isn't unusual in other parts of the world. So I just feel very privileged to actually have that position. So I've obviously COVID, I arrived just ahead of COVID, fortunately for me. Unlike Raj, I didn't have to do the quarantine. And so that did actually stop me getting into the health systems here as promptly as I would have liked to. However, in the UK, I was the trial manager and senior midwife on the UK Pregnancies, Better Eating and Activity trial, which was known as Upbeat, which was a study for obese pregnant women. And we aligned our work with Jodie Dodd at the University of Adelaide and her LIMIT study, which was how I first came to Adelaide and knew that I loved it here. So with 54% of women of reproductive age being either overweight or obese and inherent problems associated with that, that's obviously a global area of priority, and very successfully have joined Jodie's team to work on the Begin Better trial, because what we found in Upbeat and Limit and numerous other studies around the world, that whilst pregnancy was a teachable moment, it wasn't a big enough window of opportunity to put a lifestyle intervention in to improve the outcomes for mothers and babies. Both Limit and Upbeat have done follow-up studies and which have suggested that in the 3 to 4 year old children, they've already got higher blood pressure, and the babies of children of obese women they've already got higher blood pressure. Their cardiac formation is slightly different, and their cardiac function is reduced. At the moment, that's only a trend, and the women who were in the intervention group, their children were less affected than the women in the standard groups in both those studies. So it would suggest that maybe we can't influence the outcome of pregnancy, but we could influence the health of the next generation, which obviously as a midwife, that's really important for me. So the Begin Better trial will aim to will recruit women who are overweight or obese, who are prepared to delay pregnancy for at least 6 months, and they'll be randomised to a lifestyle intervention similar to the one we used before, or standard care. And then it was hoped that perhaps by maintaining that intervention for the 6 months prior to pregnancy and then through pregnancy, we will be able to impact the pregnancy outcomes and perhaps have an even bigger impact on the children as they grow up. So undoubtedly, I think we will be looking for further funding for a follow-up study for the Begin Better trial, which is now, it's got ethics approval, the database is being built, and we aim to start recruitment early next year. I've also been talking to the team out at Narlan, particularly at the Lyle McEwen, and they've introduced a fantastic digital screening tool for perinatal mental health, which basically, in response to the individual women's answers, directs them to support to maintain good perinatal mental health. And when you think that suicide is a major cause of maternal death, that's obviously a very important area. However, until I came along, they hadn't actually thought about evaluating the impact. So I'm actually working with them to actually evaluate that, because it's all very well saying you've got this amazing tool, but if the women aren't then accessing the signposted resources, then we're wasting our time. They also asked me to look at their induction of labour rates, which they thought were really high and were not necessarily in line with the South Australian PPGs. Surprisingly, we found that actually all the women who were induced in a period of audit were totally in line, which was very interesting because that wasn't the perception of the clinical midwives on the floor. But what was very interesting was that of the first-time mums who were induced, a very high percentage of them had a caesarean section and late in labour. So at the end of the first stage, or we're actually pushing in the second stage of labour. And we now know there's emerging case report evidence, and there's a clinical trial that started in the UK, that women who have a late caesarean section are more likely to have a late pregnancy loss or very early birth. in a subsequent pregnancy. So obviously that's got an implication for their future reproductive health. That fits in quite nicely. As a sideline for my PhD, I became involved in developing a simulator to train doctors to undertake caesarean sections in the late stage of labour, where the baby's head can be so low in the maternal pelvis, it's really difficult to get a hand in to lift the baby out. And there's been several cases here in Australia where babies have died. There was one baby that lost its eye, and they have skull fractures and all sorts of things. Fortunately, quite rare, but very severe consequences. And it's very easy for the doctor to put a hand through the uterine tissue, and obviously that's got implications for the future. So we've devised a gadget which is currently going through MHRA approval in the UK. It should be a CE mark, but because the UK is coming out of Europe on the 31st of January, it's got to be a CA mark, so it's got all caught up in that. But once that's done, then the team out at the Lar McEwen are very keen to do a trial of that versus standard techniques. And the other thing that they're very interested in is models of midwifery care, which have multiple definitions all over the world. And you have to really make sure people know what they're talking about. But we do know there's increasing evidence that midwifery care is important for all women, particularly those with complex needs who get a medicalised pregnancy. And as I'm going to quote Jane Sandel, who is one of my PhD supervisors, she said, all women need a midwife and some need a doctor as well. So I think midwives just need to be integral to reproductive health and childbirth. And I hope that in my role, that's what I'll be able to bring.
Excellent. So I don't really think any of us would be here without a midwife. That's literal, isn't it? So I'm sure in the corridors you've been asked many times, why do we need a clinical chair in midwifery? And more importantly though, how do you think, what are your priorities for redefining midwifery care research while you're in this position?
I think all clinical academic positions are relatively new and novel. But very, very important, because I think when you have that balance of clinical credibility, clinical expertise, but backed with the academic rigour of proper research, I just think that's a winning combination. I think for me, it is about making sure that we all know that research for many, many years has been the domain of the medics, and we've been, as allied healthcare professionals, maybe on the sidelines. And in terms of development, nurses, midwives and allied healthcare professionals are sort of embryonic in comparison with the medical and dentistry professions. So I think for me, it's making sure that midwifery has a seat at the table. And is included in all aspects from the design of the study, and the co-design stuff is amazing. I've already talked to them about setting up a PPI, a patient participant involvement group, which I'm very used to having in the UK and wouldn't put a grant in without input from patients and public. So it's just making sure that we're there as allied healthcare professionals and as midwives at the table at every stage of the research process. But we're also there to be the advocate still for the women. So I'm still an advocate for the woman, but for the woman who's taking part in research as well as providing care. And also to be inspirational for the next generation. I think we've got to be out there. We've got to research, and a career in research has got to be seen as a potential pathway for the students coming through now, because they're the future.
That was a brilliant answer, don't you think? That was, yes. Thank you. We need more clinical chairs for sure. Now, Sue, I'm going to ask you for some pearls of wisdom. You've got an outstanding record in working with industry partners. And I'm sure there's lots of MCRs and ECRs in the audience, and even some of our leaders who would like maybe a pearl or two, a gem on what do you think are the important elements to successful partnership with industry as a leader in research in the CFI?
You have to be prepared to put a lot of time into building the relationship. That's where it starts, and it has to be there has to be a lot of trust, and there has to be a lot of respect. And if that doesn't exist, you'll go nowhere. And I think always and it is interesting, I have two masters, two organisations that I need to keep happy. And understanding the complexities of both organisations and what the tensions are, because an industry-based partner is about certainly providing care in the aged care sector, but it's also a business, so that the priorities for them can be very, very different to the priorities for a researcher at a university. So understanding those differences and being able to work across them is really important. But, you know, as in any relationship, it's about trust, it's about respect, and about having common goals. And I can't emphasise enough that amount of time that it takes to build those and then have a decent co-design and co-production methodology that you use is really what's important.
Yeah, I totally agree. Do any other members of the panel have any other pearls to add to that from their experience with industry partners? Raj, are you thinking?
I think Sue was spot on. I think it's extremely important to invest that time and energy, and also this willingness to work together. Sometimes what happens is people who are working in academia are considered as these people who are working in their silos. You know, it's difficult to reach out to them. So I think as long as we are open enough and using the same language and showing the initiative, and of course then building the trust and the respect, mutual respect, I think that's a wonderful way to start.
Fantastic. Now, Julie Ratcliffe is taking CFI research straight to the top. You've been reporting to and presented to a Royal Commission. That's quite incredible. So how do you think the Royal Commission into Aged Care will redefine care, particularly in aged care, and the effects in CFI research?
Yes, so that's a very good question, and I think that, you know, the research that the Caring Futures Institute has led, you know, a very large-scale survey of the Australian general public, we found that over 90% of our participants agreed that the government should provide more funding for aged care. So that's probably the number one take-home message there. But of course, we know that funding needs to be spent in the best ways possible. So we need more skilled and trained aged care staff. We need more nurses in aged care. We need to value our aged care staff more highly. We need to ensure that those staff are well equipped with the fundamentals of care to be able to deliver the best quality care possible. Certainly from my perspective as a health economist, I'm very passionate about the need for routine public reporting of quality of life and quality of care experience for older people in aged care. So we should be regularly monitoring and assessing older people's quality of life and quality of care experience from their own perspective, and we should have public reporting of that type of data in an ongoing fashion in the aged care industry across the sector. We should also have and I hope that, you know, the Caring Futures Institute will be the leaders in this. We need more skilled and trained health economists who are passionate about aged care and about aged care research, collaborating with the wonderful colleagues in the Caring Futures Institute, including my esteemed colleague here, Professor Sue Gordon, Professor of Aging. You know, this is what's needed, and it's very badly absent. That's not a very good phraseology, but you know what I mean. It's currently absent in Australia, so we really need that moving forward, and we're hoping that that's what we'll be able to pioneer in the Caring Futures Institute.
As you were talking, Julie, my brain was only saying two things. There's lots of work to be done, but there's lots of opportunity for the college and maybe lots of money coming our way to CFI. Good news.
Let's hope so.
I was just thinking, Raj, are you actually the first professor of audiology in our state as well? Possibly. We have to we'll have to research that, get it? That is something, I think, you're the first professor of audiology that I've ever met.
Fair enough.
And I think it's saying something for CFI, definitely having leadership in allied healthcare, yay, for allied healthcare team, because professorial positions, whether they're clinical positions or academic positions, they're not that common, are they?
No, they're not.
No, they're not.
Yeah.
You're from OS, so you know that to be true. So, well done, and I'm glad that it's in our college and in our state. So, lots of interesting things in your research. How do you think audiology will redefine care? What are innovations? Do you have an app or anything?
Yeah, absolutely. I think I was discussing with some of my colleagues that if we have to look at one of the positives COVID-19 has inflicted on us, that is the way things have moved forward in terms of technological innovations and in terms of how adaptable people have been from different industries. And I think the same thing is true with audiology as well. We are talking about issues like student placements, challenges of international student teaching and learning, and of course clinical research as well. So for example, I have a PhD student based at UCL London, and she couldn't continue the clinical studies she planned for obvious reasons. However, in South Australia, that situation can be slightly different. So I think we need to be always open to innovation. That's extremely, extremely important. This morning when Alison was talking about the caring model and the Maslow's hierarchy, I think hearing is an extremely important part of all of that. And I think some of the work which my colleagues have been doing in the area of tinnitus management, it's absolutely novel, because we all know that tinnitus is a very complex, heterogeneous condition. It's beyond the expertise of one discipline, and that's why it's extremely important to involve researchers from all walks of disciplines, like neurologists, psychologists, psychiatrists, of course, audiologists as well. So I think in the next 3 years, I'm really looking forward to be doing some of that work here based under the umbrella of Caring Futures Institute, and of course involving a lot of other industry partners and other academics throughout Australia as well.
Fantastic. And I love the way you talked about multi-D within the CFI.
True.
And obviously Julie and Sue have already acknowledged each other teaming together. Annette and I have had a couple of conversations about cardiovascular disease and pregnancy. There's so much work to be done there. And the ophthalmology guys have come to talk to me about, they've got a machine that goes bing, that can diagnose or look at the vessels at the back of the eye and perhaps diagnose cardiovascular disease. And they wanted to incorporate AI, and I happen to know or be working with probably the only AI cardiologist in Adelaide, and we've brought those teams together. And so it's really interesting how this natural synergy is forming between us and within us in the CFI. So that's very exciting for the future, for the next stages. Obviously, all of us sitting here are looking forward to winning the big bucks to make all that happen as well. So I don't know if we have got any more time. Yes, okay, so we'll wrap that up. Very proud to present to you 4 of the CFI leaders today, give you a tiny chocolate box sample of their research, certainly throw out to you some incredible opportunities, and I'm sure ECRs and MCRs in the audience and on the Zoom, don't be afraid to contact any of our leaders and say, hey, I'm interested in that, can I come and join your team? Because that is really important to us as well. And we don't always know what you're doing, but it's, no problems at all, and we've always got time for mentoring and supporting the next generations within our college as well. So thanks everyone for listening.
Thank you.